The breakthrough was the Scribner shunt, invented by Dr. Belding Scribner. Before this, dialysis was a temporary fix. The shunt allowed permanent access to the bloodstream, meaning a patient could live indefinitely on the machine. Suddenly, kidney failure wasn't a death sentence. It was a chronic condition. But the treatment required a massive machine and huge staff support. The Seattle Center had roughly 17 slots. There were thousands of eligible candidates. Dr. Scribner said he could not make the choice alone. He refused to play God. So, the hospital administration created a committee. They formed the Admissions and Policy Committee. It was composed of 7 anonymous citizens: a lawyer, a minister, a banker, a housewife, a labor leader, a government official, and a surgeon. They were given the task of reviewing the files of medically eligible patients and deciding who would get a slot and therefore live, and who would be rejected and therefore die. The public quickly dubbed them the God Committee. They were ordinary people handed an impossible moral burden. The selection process had 2 steps. First, doctors screened for medical suitability. That was the easy part. The hard part was step 2. The committee looked at social worth. They looked at the patient's life. Were they married? Did they have children? Did they have a job? Did they go to church? Did they have potential to help the community? They were trying to maximize the social return on investment. They reasoned that saving a father of 4 was better than saving a single drifter, because saving the father also saved the family from destitution. The problem, of course, was bias. The committee members were mostly white, middle class, and suburban. Unconsciously, they selected people who looked like them. They favored steady jobs, church attendance, and Boy Scout leaders. They rejected prostitutes, alcoholics, and people with unstable work histories. Bioethicists later called this the Henry Higgins effect. We prefer people who reflect our own values. They were applying a crude utilitarianism, but it was filtered through a lens of bourgeois morality. It violated the principle of justice, which demands we treat equals equally. In 1962, journalist Shana Alexander wrote a sprawling article for Life magazine titled, "They Decide Who Lives, Who Dies." It blew the lid off the secrecy. The American public was horrified. They saw a room of people debating the value of a man's life based on whether he attended church. It offended the American egalitarian instinct. It also highlighted the cruelty of the market. People were dying simply because the machine cost too much money. This article is widely credited with launching the field of bioethics. It showed that these were not medical decisions, they were moral ones. The pressure grew for a decade. Finally, in 1972, Congress acted. They passed the End-Stage Renal Disease (ESRD) entitlement. This law expanded Medicare to cover dialysis for virtually every American, regardless of age or income. It is the only disease-specific universal health care program in the U.S. Congress solved the ethical problem by drowning it in money. They essentially said, "We refuse to ration life. We will pay for everyone." It was a triumph of egalitarianism, but it was also incredibly expensive, far exceeding budget projections. However, you can print money, but you can't print kidneys. While dialysis became available to all, organ transplants remained scarce. You still had to wait for a donor. This led to the National Organ Transplant Act, NOTA, of 1984. NOTA outlawed the sale of organs, banning the market approach, and established the United Network for Organ Sharing, UNOS, to create a national, fair system. They had to decide, if we aren't using social worth, what criteria should we use? Today, UNOS uses strictly objective criteria. They look at medical urgency. How sick are you right now? For livers, we use the MELD score, model for end-stage liver disease, which predicts your risk of dying in the next 90 days. The sickest person goes to the top of the list. They also use wait time and biological match. They explicitly ban the consideration of wealth, celebrity, or social worth. A homeless person with a high MELD score takes priority over a billionaire with a low MELD score. This is an attempt to create a blind justice system for biology. But the system isn't perfect. Wealth still helps. Steve Jobs famously got a liver transplant by listing himself in multiple states, something only a person with a private jet can afford to do. By being on multiple lists, he increased his odds of a match. This multiple listing is legal, but controversial. We also face the issue of personal responsibility. Should an alcoholic get a new liver? The public often says no, but the medical establishment generally says yes. Studies show recidivism is low, and if we start rationing based on fault, where do we stop? Do we deny care to smokers? To the obese? We stick to the medical need, not the moral judgment. To conclude, Lesson 2. We moved from the subjective, biased judgment of the God Committee to the objective, algorithmic judgment of the MELD score. We tried to remove the human element to ensure fairness, but scarcity remains. We are still choosing who lives and who dies. We are just doing it with math instead of meetings. In the next lesson, we will look at a different experiment. Instead of rationing at the bedside, what if we rationed at the state legislature? We will examine the Oregon Health Plan experiment of the 1990s.